You guys can hear me and see my screen? Good. All right.
Yes, sir.
Now, just to tell you guys that my salary as a first year was 7,500 per year. So
Thanks for the perspective, Dr. Abernathy.
just just to let you guys know that. All right. So today we're going to talk about the how to approach a child with edema. So mainly, I'm going to concentrate on GI issues, but we're going to go through a little bit of general approaches for these patients and things like that. All right. So first of all, let's see if we can do a case study. A 3-year-old male child is a refugee from an African country brought to the pediatrician's office with failure to thrive, vomiting, and diarrhea. So the pediatrician went in to see the patient, saw that the child has a pretty much discharged abdomen, hepatomegaly, bloating, and had some pitting edema in the legs as well as in the buttocks. So he decided he's going to hospitalize the patient. So you guys are on the ward, and you need to think what you need to do at this point. Anybody have an idea? Anybody wants to turn on the mic and tell me? No takers. Well, child is with the edema and bloating and things, so it's possibly GI, possibly some other causes. So we just did a screening blood work. And you're able to see the test results? Good. All right. So obviously child has a normal blood count. It seemed like mild lymphopenia, as a hyponatremia, and as a little bit of alkalosis, as bicarb of 32, is hypoproteinemic, hypoalbuminemic, but his liver numbers are normal. And he had some stool studies done that were negative as well. So we have a child that has got edema and hypoalbuminemia. So we're going to see what are the causes for hypoalbuminemia now, or edema rather. So as you can divide that into cardiac causes, renal causes, hepatic causes, infections, infestations, and malabsorptive disorders, etc. So we'll go through that quickly, few of those things, and we're probably going to concentrate more on the GI causes in this talk, okay?
We're going to try to take as many areas at once.
Now, causes for edema is basically a alteration in the Starling forces. Starling forces are the forces that regulate fluid movement between the interstitial space and the plasma compartment, all right? There is two components to these forces, the hydrostatic pressure and colloid pressure or oncotic pressure. So it's present both in the intravascular compartment as well as in the interstitial compartment as well. So if you remember the physiology,
Yeah. Is that 26? Actually, 25th was the day I got it. Okay.
and
I think you're good to go then. So she had the first shot January 4th. Then 3 weeks later she got COVID, and now it's been a month. And that's the antibody.
Hannah, can you mute your computer? All right. Then now that the colloid pressure is mostly from the serum proteins, most of it, the majority of that comes from albumin, and hydrostatic pressure was from the electrolytes that you have. So essentially, that's why the Starling forces are. As long as the forces are maintained adequately, there is fluid flow between back and forth is maintained, and you won't have any problem with edema. So this next slide shows that in a cartoon form. There's a schematic representation showing that the oncotic pressure pulls water in from the intravascular oncotic pressure pulls water in, and the hydrostatic pressure from the interstitial space pushes water in as well. Okay, the other way around, if interstitial, the oncotic pressure in the interstitial space pulls the water out, and hydrostatic pressure in the capillaries will push the water out. So this is the change dynamic that goes on there. So there are certain conditions where you will see alteration in this forces. In this slide, you can see that. So which one are you seeing? Are you seeing my screen with the? Which screen are you seeing? Are you seeing the screen with my server on?
Can you maximize your PowerPoint screen for us?
So you're seeing this screen?
Yeah.
Yeah.
Okay. Now can you see me better?
Yeah.
That's better. Thank you.
Okay. All right. Good. Now, there is generalized causes for edema in childhood. There's divided into several different areas, mainly into generalized edema and localized edema. The causes for localized edema are mostly local, either venous compression or thrombosis, etc. The generalized edema is usually due to generalized systemic causes, either heart failure or primary renal insufficiency or drug-induced causes, or hepatic cirrhosis that will cause ascites and edema, etc. Or renal causes, nephrotic syndrome, liver failure, protein-losing enteropathy, and protein-losing malnutrition, etc. will also cause the same type of systemic changes. So it will cause generalized edema in that case. The increase in capillary permeability is usually due to congenital causes such as hereditary angioedema, allergic reactions, that type of thing can cause angioedema that tend to be localized also, but it can be generalized too as an hereditary angioedema. So albumin is a serum protein synthesized in the liver. It's a major component of plasma proteins, and it's a carrier protein with multiple functions. And most important function is maintaining the stalling forces in the intravascular system. As you all know, that it also carries calcium. It also carries amylase and like other proteins on it, enzymes on it as well. So hypocalcemia will lead to several other alterations in your vascular system. So the causes for hypoalbuminemia, just as like you went through, cardiac causes are heart failure, congenital anomalies, or superior vena cava syndrome. That's mostly the renal. The renal causes are the nephrotic syndrome, or acute renal failure, or chronic renal failure. Going on to the liver, acute liver failure, drug toxicity. Usually you won't see ascites and things in acute liver failure, but at the end stages of acute liver failure, you can start seeing that. But drug toxicity and cirrhosis will tend to give you the ascites and more chronic condition rather than acute. Malabsorptive causes of protein calorie malabsorption. We'll talk a little bit more about it later on. And milk protein intolerance. This is one thing that you guys have to remember. If you guys remember all the babies that we see on the floor with the significant milk protein intolerance, if you look at their albumin, the albumin will be very low because they do develop a protein-losing enteropathy. So They will have a hypoalbuminemia, and eventually they will develop edema and etc. All this as well. And then celiac disease and lymphangiectasia is an unusual condition that's multiple causes for it, and we will go over that in a minute as well. And we're going to be talking about the protein losing enteropathy in general, and the IBD and C. difficile infection is a very common cause for protein losing enteropathy. There are certain infections that can cause it. C. difficile is one. Yersinia is like another one. It can cause, my TB infections can cause it. The other parasitic infestations such as entamoeba and giardiasis can cause changes in the GI tract and cause problems. And cestors, or they can block the GI tract and cause some problems. Filariasis is more of a parasite that causes local lymphatic changes and causes elephantiasis or big legs and things like that. It's not common in the United States, but it can be seen in South America and in Asia. So we went through this one, this causes for the childhood edema early on. Now we're going to quickly go through the causes for the glomerulonephritis in children. It can be either with a low complement or a normal complement. The low complement is secondary to primary renal disease, or it can be post-streptococcal glomerulonephritis, or complement-mediated membranoproliferative glomerulonephritis. Obviously, streptococcal glomerulonephritis can be a temporary issue, but complement-mediated membranoproliferative glomerulonephritis tend to be a chronic condition. And the systemic causes, systemic lupus, SLE, or subacute bacterial endocarditis, nephritis due to shunt malfunction, or immune complex membranoproliferative disorders can also cause this problem as well. The glomerulonephritis with the normal complement levels are usually IgA glomerulonephritis, or Alport syndrome, or Henoch-Schönlein purpura, associated glomerulonephritis, or Goodpasture's disease, are the most usual causes for that. So shifting gears from here, we're probably going to switch over to GI causes for this problem and start looking at how the GI problems occur. And first we'll start with the lymphatic system. As you all know that the lymphatics are the main transporters of the proteins and fat and extra interstitial fluid from the distal part, different parts of the body into the vascular system. You can see that it goes through all of the lymph nodes and then on through the spleen and then drains through the thoracic duct into the vascular system. So any blockages or alterations in the system can cause the back pressure in the lymphatics, and that can lead to leakage of fluid from the lymphatics. Especially if a cisterna chyli or a thoracic duct gets blocked, it tends to happen in patients that have a cardiac surgery. They do develop that blockage into the intestinal lymphatic system, and they'll start having problems with leakage. So this slide kind of gives you causes for protein losing enteropathy. This can be either inflammatory exudation or lymphatic obstruction, or due to increased permeability through the wall, due to either ulcerations or destruction of the mucosa. Okay, inflammatory exudation due to mucosal erosion or ulceration is usually seen in the inflammatory processes, Crohn's disease, ulcerative colitis, or in gastrointestinal malignancies, gastric cancer, lymphoma, Kaposi sarcoma, alpha chain disease, etc. Most we see more commonly in pseudomembranous colitis or in the milk protein intolerance. The one drug that we do need to remember about developing the protein-losing enteropathy and diarrhea is the non-steroidals. This can be a significant problem. This can cause prolonged protein-losing enteropathy even after stopping the medication for a long period of time. Post-chemotherapy, there used to be atrophy of the vessels and things, and they may cause or inflammation of the small bowel mucosa due to radiation or chemotherapy that can cause changes as well. Okay. And polyposis is simply due to enlarged size and blockage of the vessels and veins and lymphatics, especially think conditions like familial polyposis, where they have a big carpet of polyps in the small bowel. They can develop this problem. Similarly, graft versus host disease also same thing that can cause inflammation and cause leakage, etc. Now, lymphatic obstruction, that usually can be primary intestinal lymphangiectasia, which is a bit unusual disease, but rare, but it's a lifelong problem that in those patients. Heart failure can cause by causing increased congestion and obstruction to the drainage of thoracic duct. So it causes back pressure in the small bowel, and that leads to protein-losing enteropathy. Similarly, constrictive pericarditis is also a similar problem. And congenital heart disease are actually the corrective procedures that's done for the congenital heart disease is what causes the problem, especially the Fontaine procedure patients that done for single ventricle uniformly develop protein-losing enteropathy. They can have chylous ascites, etc. as well. The retroperitoneal lymph node enlargement, either due to chemotherapy, infection, or hyper-IgM syndrome or hyper-IgE syndrome, these people will tend to have significant leakage as well. And finally, the cirrhosis not only causes ascites in other ways, it can also cause back pressure in the small bowel and also lead to lymphangiectasia and eventually go to protein-losing enteropathy as well. Hepatic venous flow obstruction, once again, the same way. And mesenteric vein thrombosis, similarly, the sclerosing mesenteritis, which is an autoimmune disease, same thing. And the chronic pancreatitis with pseudocysts, they usually cause blockages in the vasculature, usually splenic vein thrombosis, etc., which leads to pressure back on the lymphatics and then causes lymphangiectasia that way. Whipple's disease, once again, it's a small bowel disease. It's usually an unidentified bacteria that causes blockages, and that can cause locally lead to lymphangiectasia. Retroperitoneal fibrosis is also a autoimmune disorder, or it can occur even after chemotherapy or radiation. That can also cause the same problem as well. We're going on to the conditions where you have a mucosal injury that causes problem. The common one that we always have to think about is the celiac disease. Our Menetrius disease is another condition that we need to think about. Those of you remember Sultan, John Terrius Sultan, he does have this, his albumin is always low as well. He comes in with severe anemia and all those things. That he does have this problem as well. That's usually because the gastric folds are so enlarged, they exude fluid, blood, everything out, so that causes them to develop low albumin as well as it causes significant anemia. Secretory hypertrophic gastropathy is this is what possibly the Zollinger-Ellison syndrome that can also lead to increased fluid secretion in the stomach. That not only acid, it also will have some protein as well that lead to get to hypoalbuminemia. Infections, acute parasitic infections, Whipple's disease, viral infection, bacterial overgrowth, all of these can damage the lining and cause the changes that in the lining that will lead to that. One little bit about the eosinophilic gastroenteritis. A little bit eosinophilic gastroenteritis. This one is different from eosinophilic esophagitis that we always talk about. This is diffuse disease in the small bowel as well as in the colon. This can cause significant secretory diarrhea due to, as well as mucosal injury that can produce severe hypoalbuminemia in these patients. Collagenous colitis is mostly seen in older people, and it's not something that we'll come across in pediatric age group that often. These are all the congenital disorders of glycosylation and the heparin sulfate deficiency are very rare conditions, but they are severe when they occur, and they tend to continue to have problems all their life. So we saw all these patients, the causes for the protein losing enteropathy. Now, what are the clinical manifestations of it, and what are the laboratory abnormalities that you will see in these patients? Obviously, hypoproteinemia, you're going to develop edema, and you have conditions where there is hypoproteinemia is chronic and significant, especially with patients with cirrhosis on top of it. They can develop ascites, pleural effusion. The pleural effusion tend to be chylous effusion in these conditions rather than regular pleural effusion. Or they can also get the pericardial effusion as well. The laboratory abnormalities that you'll see is the hypoalbuminemia. And this hypoalbuminemia is without proteinuria. So you always have to check the urine to see if they have proteinuria so that you can confirm that all the hypoalbuminemia is due to GI losses rather than anything else. Sometimes hypoalbuminemia can be due to decreased protein synthesis that's associated with the cirrhosis or severe malnutrition as our patient is. And this also will lead to reduced gamma globulins and cholesterol and the alpha-1 antitrypsin and fibrinogen, ceruloplasmin. All the serum proteins will be low. Obviously, lymphangiectasia will also, the lymphatics carry out and push all the lymphocytes out into the GI tract, so they will develop lymphopenia. And also they will have malabsorption of fat-soluble vitamins as well. So there's a patient with the primary lymphangiectasia as a generalized pitting edema in her legs. And this is called Wallmann's disease. And there's the usual appearance of that. Now, there is one diagnostic test that's easy to do and confirmatory for lymphangiectasia. There is alpha-1 antitrypsin clearance test. The way it is done is the alpha-1 antitrypsin is some amount of it is secreted into the intestinal tract. So you can measure the amount of alpha-1 antitrypsin that comes out in the stool. So you collect a 24-hour stool sample and measure the level of it, of that in the stool and alpha-1 antitrypsin concentration and the volume, and you multiply that and divide that by serum alpha-1 antitrypsin level. And that will give you a number, how many milliliters of stool contains that. It can be the 2.6 milligrams per gram of stool, or if you're looking at the volume, it's 30 milliliters per day, 13 milliliters per day. If this number is high, that is 27 milliliters per day, or in a form stool, that is significant, that's considered diagnostic for protein-losing enteropathy. If it's a diarrheal stool, it's more than 56 milliliters per day of alpha-amitripsin excretion, is considered diagnostic for protein-losing enteropathy. Once we confirm that, once we've done a urinalysis, that the urinalysis doesn't show proteinuria, then we went on to do this test and say, okay, this patient has the protein-losing enteropathy based on this test. Then we need to go and do the additional workup, more going towards the diagnosis of underlying conditions. This can be regular upper GI small bowel follow-through. Here you'll see the appearance of edematous folds, and the lining will look like it's got rings on it, so it will look like a stack of coins sitting in the middle of your GI tract. CAT scan will pick up lymphomas or mesenteric lymphadenitis, lymph node enlargement, etc. If MRI can show you IBD or infectious colitis, etc. More definitive diagnostic procedures will be upper endoscopy. Here you can identify lymphangiectasia, giardiasis or celiac disease, or etc. And colonoscopy will show inflammatory bowel disease, C. diff, colitis, or other causes for. In older people, it's a colloidal colitis, collagenous colitis in older people, etc. So that will be the next step in the workup. So how does a lymphangiectasia look under a microscope? Is it just a low field view? You can see that there's a villi are properly present, but there is significant enlargement of the lymphatics here, here, and here. Multiple areas you can see that lymphatic enlargement. In this one, you can see a little bit better. So large lymphatic channels that leak out the fluid. So the consequence of this is that you are going to lose a lot of your fat, as well as the protein in the GI tract. So how are we going to manage these patients now? Main thing is to dietary therapy. Is it just that main to improve nutrition? The diet should be low fat, high protein, high medium chain triglyceride diet. So long chain triglycerides, you cannot completely eliminate them because that's where most of the essential fatty acids are there. So you do need to use some amount of long chain fatty acid in your diet so you can get enough essential fatty acids without developing deficiency. So we always want to get a dietitian involved in here so they can manage this and get this one going, okay? In infants, usually if you have a child that has got significant chylous ascites, those of you might have seen some babies on the NICU, usually we go with a formula that's got very high amount of MCT oil in it. So one example is Enfaport, or even all the synthetic formulas that we have, Yellowcare or Neocate, all of them will have more than 70% of the calories come from MCT oil fat rather than regular long chain triglyceride fat. So don't use any normal formulas in these babies. Now, next is to make sure that you treat the underlying disease. So that just improving the nutrition alone is not going to be good enough, but you do want to improve their underlying disease to treat the If it is cardiac disease, go ahead and treat them for heart failure. So you get them going better. And unfortunately, if they have a Fontan procedure or anything, and they have lymphangiectasia secondary to that, you can't really do much about it. You just need to live with it. Okay. We need to, there you just they're managing the condition. So you're mostly relying on your diet changes rather than your underlying pathology treatment. Controlling the inflammatory bowel disease is a very good way of getting them better. Then you don't have to be on a restricted diet. They can go on to the regular diet. C. difficile usually is a temporary condition. So hopefully you don't have to be to treat them for a long term, but the dietary management, treating the C. difficile will quickly turn them around. And I didn't put that in milk protein intolerance here. Obviously, you guys know that. So once you have once we document that somebody has a milk protein intolerance, go and change the formula to a synthetic formula, then you treat that condition and quickly they revert back to normal, and you don't have to worry about the dietary changes as much, except to continue the elemental diet. And if you think that the drugs that is causing it, then discontinue the drug. Similarly, I'm just giving the example of NSAID because that's what causes protein losing enteropathy. If it is other conditions, you do need to think about calcium channel blockers and things like that. Also, that can also lead to the same problem. If the disease is refractory, then we can get some relief by reducing the amount of area where you're going to lose the protein. So resection of a bad segment of the small bowel and reanastomosing it will give you relief at this time. All right. Now, octreotide, which is a somatostatin analog, does seem to reduce secretions and also reduce protein loss. So that's one of the reasons why, if you guys remember, we are using this on this fellow John Tarian Sultan with the Menetrius disease, where the secretions will be reduced, and hopefully we won't have him coming in to the hospital that often. And there is a anti-complement monoclonal antibody. It seemed to be effective in protein losing enteropathy, especially if they have immune mediated protein losing enteropathy. That's the underlying disease management. There's other, because obviously if you're dealing with a renal patient that has hypoalbuminemia, then you're going to deal with in a different way. You're going to treat his underlying renal disease and also manage him with intravenous albumin infusions depending upon these conditions. Okay. The intravenous albumin infusion is beneficial in certain conditions. You have to use it in conjunction with a loop diuretic. If somebody has an underlying pathology where they are losing the protein and their intravascular volume is depleted, just putting the protein into the intravascular compartment alone will not relieve your edema. So what you need to do is give them albumin, and that will suck in the water in there, and immediately you need to excrete that out of the intravascular volume. So you follow that with the Lasix, so they will have a significant diuresis that will reduce the edema. So that's what you need to do. You always have to go with a albumin infusion followed by diuretic, especially Lasix. So the usual Dose is 1 gram per kilo of salt poor albumin, followed with Lasix. And this can be repeated every 6 hours or so, or on rare occasions, you can put it in a TPN on top of TPN and gives us continuous infusion, and follow the Lasix every 3 to 4 hours or every 6 hours or so to get relief from that. So it's especially useful in children with nephrotic syndrome or children with cirrhosis and severe ascites. In children with protein-losing enteropathy and malnutrition, it's only temporizing. But there you probably want to concentrate more on your diet and management of that rather than anything else there. Okay. Whenever you're working with hypoalbuminemic patients, remember it's low albumin that means low colloid pressure in the intravascular system. The hydrostatic pressure is not altered. So you do want to restrict salt in their intake in all these patients with hypoalbuminemia. So there should be always salt restriction in these patients as well. So that's about our management part of it. So now we're going to talk what happened to our patient. Our patient, the one that we saw early on that came into the hospital. So he's a 3-year-old that moved from Africa to here, obviously significantly malnourished and things. So he probably has protein calorie malnutrition. Okay. So what kind of protein calorie malnutrition? So he probably has a kwashiorkor because he has edema. So this table shows the difference between marasmus and kwashiorkor. Marasmus is basically due to the generalized calorie loss. Here, they probably do get some calories, but their protein intake is very low in kwashiorkor. Okay. So the marasmus, they are low weight and their height and weight is low. Height for age is their stunting because in general, they don't have any calories. The head is rather large because the body is cachectic. Okay, so the extremities look like emaciated arms and thighs and buttocks and loose folds and muscle mass loss and all those things, loss of subcutaneous fat. Typically, they are very irritable and fretful. Skin is thin and dry. Hair is falling off and sparse, and they can be easily plucked. Okay, kwashiorkor, that's what we call as edematous kwashiorkor. Here, they may be getting lots of carbohydrates, but not getting protein in their diet. Okay, so the weight may be variable. They may actually look like they are nourished. They may have a big head and big face and things like that, like his moon face. And prominent cheeks. They may even have facial edema, but they may appear plumply because they do get a lot of carbohydrate, not much protein. But the edema can be variable from mild, just only in the feet, all the way to generalized edema. Okay, our patient probably falls into moderate because he has his feet and legs and edema as well. So that's the group that he falls into. And usually they're just laying around and they are listless. The belly is usually distended, bloated, dilated intestinal. If you do an X-ray, you'll see any dilated intestinal loops. They will also have a hepatomegaly as well. They also have a thin, dry, peeling skin with areas of hyperkeratosis and things like that, hyperpigmentation. It's called dermatosis. I'll got his next slide. I will show you that. The one thing interesting is the hair. These patients would have had various stages of getting some protein in their diet, that loss of complete malnutrition. So they will have various areas of hypopigmentation. So you can see, if you look at their hair, pull out, they can still pull it out rather easily. If you pull it out and look at it, they'll have like strips of hypopigmentation, normal pigmentation. So that's what we call as a flag sign in these patients. All right, this is the slide of a child that has kwashiorkor dermatosis. As you can see, got significant edema, the edema of the scrotum, the edema at the bottom, edema of the legs. but significant keratosis in all these areas, and desquamation, this bit peeling, and etc. That's a common thing. That was what you'll see. And our patient did not have this, but he did have other changes of kwashiorkor, and that's what his diagnosis is. And that also led to this hypoalbuminemia as well. So in summary, hypoalbuminemia has multiple causes. It's a common cause for your edema. So management of hypoalbuminemia depends upon the underlying cause. Okay, if it is an acute, then you don't have to really manage it that much. You just treat the acute problem, like treat the C. difficile or treat the IBD, then they will get better, and you don't have to worry much about hypoalbuminemia. There are multiple causes for protein-losing enteropathy, but primary management is dietary in those patients. So there you may not have to use albumin infusions as often. You will see a gradual improvement in their albumin status, and the edema will disappear, everything will get better. Milk protein intolerance and C. diff infections are the most common pediatric causes. And luckily, both of them are temporary. So you can just treat both of them and they will recover. The hypoalbuminemia will disappear as well. Okay. And we always have to manage the underlying pathology to manage this hypoalbuminemia, to be successful in hypoalbuminemia management. All right. The management, it should involve a dietitian, social worker, and the active involvement of a pharmacist as well in this, along with the physician. All right. Good. That's all I had to say. Do you guys have any questions?
Dr. Amarnash, this is Colin from the NICU. I have a quick question. So I understand you were talking about protein-losing enteropathy. We're saying that one of the treatments is you want to try and increase the patient's protein intake. I understand that, but I was wondering why you want to have a low-fat intake. How does that relate to PLA?
Remember, if you remember your digestive physiology, when you digest there's a fat, the long chain triglycerides or long chain fatty acids are transported through the lymphatics, right? The MCT, medium chain triglycerides, are absorbed directly into the bloodstream, okay? So when you have high fat, high long chain fat diet, you're going to cause them to have increased intestinal fluid, lymphatic fluid in the intestinal tract. So when the intestinal fluid when you have a lymphangiectasia, that causes leakage of fluid, all right? That all that fluid is going to pour into your GI tract. You're going to digest it, absorb it into the lymphatics, and then pour back into the GI tract, okay? And along with that, the drainage, you're going to lose all the protein along with it as well, because lymph has not only just the fat, but it also has significant amount of protein as well. The albumin as well as globulins, all of them are there. All of them are going to leak out. Okay, so if you want to improve their nutrition, give them adequate calories and fat, you want something that gets absorbed directly into the bloodstream. So that's why you reduce the fat, the protein goes in there, and the MCT goes into your bloodstream, so you get more nutrition that way. Okay?
Thank you.
All right, good. Anybody else? Very good. See you guys. Bye.
Thank you. Bye.
Thank you, sir.
You're welcome. Bye-bye.